Well, good afternoon and welcome to the Improving Care Coordination by Working with Superutilizer Patients follow-up coaching call. We hope you were able to join our June 27th webinar. If not, Jamie, I believe, will provide that in chat, and it's also on one of the slides. My name is Tammy Bauman. I'm with Great Plains Quality Innovation Network. I'm a quality improvement advisor on our care coordination team. Great Plains QIN is a Quality Innovation Network quality improvement organization for Kansas, Nebraska, North Dakota, and South Dakota. I'd like to welcome and thank you for participating in our coaching call today. Today's event will be recorded and posted to our website, greatplainsquin.org. It will take about 7 to 10 business days to be able to access this coaching call recording. There will be an opportunity for questions after today's presentation, or you can post any questions via the chat function on the bottom right side of the screen. Jamie Stagg will be monitoring the chat feature throughout today's webinar session. So this coaching call is for you to ask questions and gain insight on how to develop a program maybe in your area. We ask for your participation and to use this time to be engaged and interactive with Laura and other participants on the call. So right now, if you could, while I'm introducing Laura, please chat in who you are and where you're from and what you're interested in learning more. Today's speaker is Lara Shadrach, and it's my pleasure to once again introduce her. She joined Mountain Pacific Quality Health in December of 2014, and she provides leadership and coordination in some of Montana's largest communities to reduce unnecessary hospital admissions and readmissions. Laura wrote for and earned Mountain Pacific Quality Health a nearly $1 million award from Centers for Medicare and Medicaid to implement the Special Innovation Project Resourcing for Superutilizers in a Rural Setting, an application of hotspotting philosophy. By introducing this model into the communities in which she already facilitates collaboration and quality improvement, healthcare providers will identify and better support high-cost, high-need Medicare patients who are superutilizers of healthcare services, furthering the statewide goal to reduce avoidable hospital admissions and readmissions. So we thank Laura for taking time to be with us on this follow-up coaching call and for sharing her knowledge and expertise with us. So I'm going to turn the presentation over to Laura to provide a brief overview of key takeaways and lessons learned during her team's development of the program, and we will open up the lines then for you to ask questions and share. So there you go, Laura.
Well, thank you very much. Can you advance to the next slide, please?
You bet.
So because we have just a little bit of time, I'm just going to briefly go over a little bit of what we discussed in the last webinar and then address questions. So to me, this was the summary of what we learned in our project working with complex care patients, also known as superutilizers. During our June webinar, we talked about the 3 realms of patient care, more specifically complex patient care. And with that, I'd like to start with a couple questions. Are the questions on this slide, Tammy?
They are. And do you want me to just go ahead and ask those?
Yeah, go ahead.
Okay. So if you are an administrator or healthcare leader, if you could chat in and describe how many or what proportion of you contracts reimburse each circle. And I'll let some maybe chat in, or do you want to expand on that at all, Laura? Did I ask that question correctly?
Yeah, I mean, basically what I'm trying to understand is what proportion of your contracts are focused on medical, behavioral, or social determinants of health. I really want us to think about how you get reimbursed and where your care is focused, because what you do depends mostly on what you get paid for.
Absolutely. So another question. Okay,
yeah,
go ahead.
Go with the other question because I want to make sure that everybody's included.
Okay, perfect. If you are a provider, such as a doctor, nurse, an LCSW or clinician, describe what proportion of time you spend addressing each circle with complex care patients. And then as we wait for some responses, what does your complex care population look like? What age, ethnicity, education level, and income levels do you see or have?
I saw something from Michelle Garcia where she says social or behavioral. Michelle, could you expand on that? Any purport? Is that what you're wanting to get out, or is it what of this webinar, or is it what you spend your time on?
I also see from Kim Scarlett, it says could range from 20 to 40 minutes depending on the situation. So time levels. Right. And Michelle put poverty, lower educated, age 50 to 70s. And that's what she finds her time is spent on.
Anyone else? Can anyone else type into the chat here?
And I'll say again, healthcare leaders describe how many or what proportion of contracts reimburse each circle. If you're a provider, describe what proportion of time you spend addressing each circle with each complex care patient. And then what does your complex care population look like? You know, ages, ethnicity, education level, income levels. We have some more. Kim also said 40 to 70s is the age range and mostly Medicare. Melissa Sanford said 60% of their time is spent on medical, 10% on behavior, and 20% on social.
Great. Thank you so much for participating in that piece.
And Camry Johnson says more of our contracts really deal with medical. However, newer contracts are entering into behavioral components.
Great. This is setting the stage perfectly. Because what I would like to really leave with you all too is how important the social determinants of health piece is, particularly in our patients that readmit over and over again through the emergency department and or through the through the hospital, and you know, taking that back into the clinical piece and what we can, you know, and haven't been doing in the past around the clinical piece, and just how important all three realms of these are. So you may recall on the June conference, we really are advocating for these circles being about the same size for complex care patients. There is, of course, many comorbidities there with chronic diseases, but there is a component of behavioral health that is in roughly about 80% of the patients, they have some sort of psychosocial component to their care. And they, you know, the social determinants of health are things like housing and transportation and health literacy and how prevalent those are. We saw that roughly 70, almost 80% of the patients have psychosocial components to their care in the patients that we saw in our pilot in Montana. And they also have health literacy issues. So top two things there that can cause challenges between all three realms here. So on to the next slide, please. What we did in Montana was a small pilot project in 3 communities, and we saw roughly around 430 patients. In that project, we piloted teams made up of nurses, community health workers, and tablets. The tablets and the CHWs allowed the teams to extend across a larger geographic area and still maintain a relationship with the nurse and the patient and the community health worker by using video chat capabilities to link the nurse and the patient and the community health worker together. So as you can see, the criteria that we used for these teams in selecting patients were patients with 2 or more inpatient admissions and or multiple emergency department visits in 6 months. Patients was not at the end of life. This is not something this is not a hospice intervention. If we encountered that referral was made to hospice. Social determinants of health. Like I had mentioned before, those are, housing, transportation, health literacy, estranged family members, like family member or relationships at home. In-home visits, we find this probably one of the keys to this model is because you don't get all the relevant information on the social determinants of health and the other aspects unless you go into the home and you have that continued intensive relationship with the patient. Lots of contact, lots of chances to talk about both the medical and the other piece. Our teams tend to develop really strong bonds with our patients. This is something that we piloted in a rural location, and being in Montana, we were in Billings, Helena, and Kalispell, which are hubs, but they have rural locations outside of them. So I think go ahead on to the next slide. There was a lot of interest in the report out in the community health worker benefits. To the program, what the CHWs do. You can see that most of what the CHW does is filling out applications and connecting resources. The critical role for the community health worker is to address the non-clinical needs. So really addressing the work in the third realm or the social determinants of health piece and coordinating resources for medical and behavioral. The role is key to being most effective because it helps reduce the drive burden and lost time for the nurse, which allows that nurse to function at their highest level, their highest clinical value. This also is a more economic business proportion of this too. The community health worker is roughly reimbursed at $18 an hour according to federal statistics. So this is a team where you have a nurse that can function at the highest part of their license and someone that helps address the non-medical needs that functions at a reasonable cost expenditure. The other benefit for the community health worker is they really connect with the patients in a unique way because they're more of a lay person and not necessarily associated with a clinical perspective. So next slide. Just really quick, there's reductions in utilizations with this program. We had a tremendous ROI. This is an example of hospital costs. Hospital data in which we saw an 8-to-1 return on investment or $1.8 million off the first 36 patients. We did also see reductions in social determinants of health. We were able to close gaps and address needs when possible. We saw an increase in patient satisfaction and an increase in provider efficiencies, as well as satisfaction that were self-reported in the interviews. So with that, that's hopefully a concise overview for the last conference, and we can move to questions.
Absolutely. Thank you so much, Laura. Now it's time for us to open all the lines and begin a dialogue. All right, we are in conversation mode, so if you're not speaking, if you would press, I believe, *6. Please, who has some questions or wants to dialogue with Laura about this super utilizer program? This is an open space for you. Please share maybe your experiences regarding super utilizers. You can also chat in any questions if you're being shy. We do have some leftover questions from our webinar, so maybe we'll start with one of those. Laura, you had mentioned on an average of 50 to 60 patient caseload in 1 year. On average, how many patients would you say you worked with at one time?
Sure. And each one of these programs is different, so I need to start that as a caveat. But the best advice I could give you when you're starting a program is to begin with just one patient. I think that was the biggest aha point for us in our programs, is like everything was just theory and concepts and literature until we actually started working with that first patient and seeing all the complexities and all the needs and really bringing folks together and solving that patient's problems. Roughly the first year we started with about 10 to 15 patients. That was in the advice from Camden Coalition of Healthcare Providers. We started that also because we were in a rural location. We didn't know what the drive time and weather would, how that would impact our program. And most of the programs carried about 25 patients at a time. There was a team that was made up of an RN and 2 healthcare workers, and that team was able to address more patients at a time. That was their caseload. Both of our interventions were done. All of our interventions were done over 90 days. And so really when you look at carrying about a load of about 25 patients and then spacing it out so that you bring on the new patients and then carry it forward, you're looking at roughly maybe somewhere between 60 to 100 patients that you could cover in a first year. But it depends on the number of patients, number of team members that you had. The model that we're able to see more patients were the 50 or the community health worker, or 2 community health workers and a nurse to get the higher number. 50 to 60 probably is a good number when you look at just a nurse and a community health worker in a larger geographic distance. So if that helps, you're going to have to look at a couple factors. The makeup of your team, the distance to care, and basically how new is your program and how many other resources such as pharmacy and behavioral health do you have around it.
Great, thank you. I'm going to open the space again just to see if someone wants to ask a question of you. So it's *6, and just wait a couple seconds to see if someone unmutes themselves.
So I see a question in the chat.
Yeah.
A couple questions in the chat.
There is one from Stephanie, and she said, how did you choose your patient, or what criteria did you use to choose the patient?
So if you could go back to the slide with the team member on there, what was that slide? One more. There you go. So the second piece, these are roughly the criteria, and I say roughly because you learn as you go along. So these are roughly the criteria that we looked at. Patients with 2 or more inpatient admissions and or emergency department visits in 6 months. A patient not being end of life, so we would look at the diagnosis. Quite often when we look at these programs, and this is something we went in, and this is something we definitely learned through this pilot, is, often when you look at super utilizers, you look at these folks that have been in and out of the hospital 5 or more times, and in and out of the emergency department, and they amount to a lot of money. But that's not necessarily who you're going to impact with this type of a pilot. Those are folks that maybe need a hospice referral or different supports around them for end of life. This is really working with patients that have social determinants of health. You may not necessarily get that from the health record, but you can see some notes in the health record or notes in the information that may give you that clue, like transportation or low income or education, that really point you into that who is the right patient. These are patients often that we would have provider intuition saying, you know what, there's something more going on with this patient. We don't know what they're, they always come in and, give us the information we need, but we just know there's something else going on with that. And provider intuition became a strong indicator for us, but it's not something that we used originally in the criteria. And then, distance to care is another piece too. So those are just generally the criteria that we used. Something else that we've toyed with a little bit and discussed was, is this an appropriate intervention for ESRD? Is this an appropriate intervention for degenerative diseases such as MS or, things of that nature? And so, we did see some of those patients, in a few of the programs, but, this is probably not, that's something you want to discuss as far as criteria and look at your own data. Another criteria that you may want to discuss too that the programs just address differently is severely persistently mentally ill. The SPMI population is probably better served through community health centers and PAC teams that go out. Those are already generally established in most states. And so, folks in acute psychosis and having a lot of needs around, hospitalization are not appropriate candidates for this type of program. They need to be stabilized and have different resources around them. So hopefully that answers your question.
Great. We have no other questions, it looks like, in chat. Again, if someone would like to ask a question of Laura, you can chat in. We have another one from Stephanie. Were they patients being dismissed from the hospital, or were they patients you saw a referral from primary care from the physician?
So, that's a great question, and I'm going to answer it. Like when we first started the program, we only took, in one of the sites, we only took patients that were in the hospital and were going to be discharged. And I think there's a really strong reason for that, and that is that you develop the relationship before you go into the home. Trying to make that cold call when the patient has no relationship with the team is a little bit harder for some of these folks. That being said, we did have a program that was 100% made on referrals. The referrals came from the hospitals after they analyzed their data. They made the call to the patient, and then the team was introduced all telephonically. So, in all the programs, we did end up taking referrals just because it became a strong indicator. There's data can only go so far, and so that's one thing I would really like to emphasize is that data is just the starting point. It is not the whole picture. You cannot possibly get the picture until you have a relationship with the patient and or some other kind of insight. That would be the one thing I could really want to emphasize is that the data is just the beginning.
Thank you, Laura. Now I heard someone maybe unmute themselves. Is there a question? No. If not, then we'll go on to another question that we had from our last webinar. How long has the group been actually doing this?
So we actually got our award in September of 2015. That was from CMS. But the first 6 months of that award, so basically September on for 6 months, was really spent on trying to get the program lifted off the ground. As you may recall from the other webinar, we had nothing. We started with no job descriptions, no contracts, no assessment tools. And so the first 6 months was really spent trying to develop those protocols, those processes, hire the team on, make sure we had the right folks, everything down to like what questions do we ask in the interview to get the right team. All those things, are kind of what we dealt with for the first 6 months. But that being said, we had talked enough about these programs that we also had some folks that were kind of going off on their own, had permission from their outpatient clinics to start applying some of these learnings, these methodologies. In particular, we worked with a cardiovascular clinic, Rocky Mountain Heart and Lung, in which that patient or that nurse picked out 10 patients and started going into the home and, started looking at what she found and then helped inform how we developed the program.
Great. Thank you again, Laura. Kind of the spin-off of that, you were talking about the home. There was a question on what were some of those restrictions that you had going inside of the home?
So let's see. A lot of attention is paid to safety. Always we have the nurse and the community health worker go into the first in-home meeting with the patient together, and that is for a variety of reasons, and safety is among those. And I say home because it could be home is an apartment or a house or a motel or a trailer, or, even in Montana, there was patients that lived in sheds, or homeless. Also, the patients, did not do things for the patient. It was like, I really need my house cleaned up. I can't get around. Well, we can connect you with house cleaning services or, home keepers that are part of this program, maybe at Area Agency on Aging. They didn't clean the house. They didn't do the dishes. They would help connect resources so that those would be lasting and sustaining supports for that patient, if that makes sense. As far as, the teams were very good at setting personal boundaries, and this is something that we're still, working with to this time, is having teams that can set personal boundaries that create a relationship and a bond, but don't get into areas like, going out to lunch with the patient or accepting gifts or, things like that. And then the other one, which is, very Montana, is we would not allow guns to be present. There is a very high per capita gun ownership in Montana, and we just, for safety reasons, would not allow guns to be present when we were doing visits. Those are just some examples that hopefully that meets where you're going.
Yes. Well, we had, does anybody have a question they'd like to ask Laura before we wrap this up, since that it's 12:43. I don't see any in chat. So with that, we're going to do here, we had some questions. We do have a care coordination and medication safety land upcoming events. You can see here August 7th, August 14th, September 20th, and 26th. Pain management, chronic care management, Medicare and beyond, talking about utilizing those CCM codes, and then medication-assisted treatment for opioid use disorder. We invite you to visit the Great Plains website at greatplainsquin.org for resources pertaining to our care coordination as well as other initiatives being led by Great Plains Quinn. Also be sure to join our Learning and Action Network if you're not currently a member to receive notifications on future educational offerings provided by Great Plains Quality Innovation Network. We're going to ask you to complete the evaluation form for today's event to offer us feedback and help us plan and coordinate future events. And feel free to contact us here at Great Plains Quinn with any questions that you have. We can also ask questions if you were shy and didn't want to ask and didn't get in chat, or you get off of this phone coaching call and say, I should have asked that question. Please send it to one of us. We will get that question to Laura, and then we will post those on our website after we've compiled them all. Thanks again for your participation today, and we hope you found the information valuable and applicable. And this does conclude our webinar. Thank you again, Laura, very much.
Sure.